right now the system isn't great for the United States, and I'm not sure exactly where it's going to go, but everybody knows it has to change. I think a single payer system would work better, but there's downs to that too. So that's why I go back and do cartoons and do games, because it's a lot more fun.
Oh, I gotta go. I've been working, told them please don't hit my phone. I'm in my zone, bruh, just leave me alone. Was on the road, but I swear I'm coming home. Now the drinks on me, I think we need a toast. See, I did it for me. Now my old friends calling, told them nothing's for free. Told me time is money, dog, swear I paid all my fees. I was starving for this game, now my family can eat.
Hey everyone, welcome to the Cup of Nurses show, here with your hosts, Peter and Matt, two nurses on a mission to change this world, one conversation at a time. Thank you everyone for tuning in. If you find value in this show, please share and review the show. It would mean absolutely everything to us. cupofnurses.com for the latest updates and merch releases. For our lifestyle podcast, you can check out wearefrontlinewarriors.com.
In this episode, we would like to introduce you to Jim Fulmer. Jim is currently a board-certified internal medicine hospitalist who has worked with nurses in a lot of different healthcare settings over a long career. He has had experience in working in healthcare in the Appalachian Mountains of Kentucky, Australia, Alaska, public health, traditional office practices, research, and in various leadership roles in hospitals. He is also a medical cartoonist on Instagram and has created a hospital-themed board game and card game called Dr. Wars. Thank you, James, for your time. Thank you so much for being here. Can you give us a little bit of background about yourself and your medical experience and where you are today in Jacksonville?
Sure. Well, thanks for inviting me, guys. I really appreciate it. I really like your title, Cup of Nurses. Very inspiring and an interesting title. But I'm in Jacksonville, Florida right now, and I'm a hospitalist. But I've always had this sort of dual career interest. I've been interested in entertainment and medicine, and so I didn't really go straight into med school. I mean, I certainly did the med school residency thing like every doctor did. But when I was in college, I was pre-med and I dropped out because I thought I was going to go into entertainment. But what is entertainment, you ask? I didn't know. You know, I've been a cartoonist all my life. I was thinking about doing stand-up comedy. They didn't have at the time, you know, it was a long time ago. At that time, they didn't have any social media, so there wasn't any possibility of that. The only way you could do stand-up comedy would be like, you know, just get up on the stage and do it. And I just, you know, so I after college, I was tried to keep my options open, and I went down to work in Appalachian Mountains in a place called the Frontier Nursing Service. You ever heard of that?
No.
You all should know about it. It's probably, I don't know if it's the first, but it's one of the first nurse practitioner, nurse midwifery training programs in the U.S. And actually, in very early on, what they did is in the Appalachian Mountains, hide in Kentucky, these nurses would go back up into the mountains, which was very isolated, and go to patients on horseback, and then see the patients, do home visits, come back, do whatever they did. And that was how it started. And then it grew. And of course, now they go up there in Jeeps. It's still very isolated. They're way up in the mountains. There's like cabins here and there. It's hard to get to. So they go up in Jeeps. And these are nurse practitioners and nurse midwives. So I went down there as a volunteer. I ended up being the health educator for the system. And I was able to use my entertainment interest by doing radio spots. I actually won a Kentucky State Hospital Award for funny comedic radio spots. But at the same time, what was really cool about it in retrospect was I got indoctrinated with nurse practitioners and nurse midwives and nursing in general. I lived in a dorm with a whole bunch of nurses. So unless you're a nurse and going to med school, unlike most doctors, I went into med school feeling like, nurse practitioners and nurse midwives have great value. And, I learned how to communicate with them. So from the very beginning, before I even went to med school, I was interested in how you communicate in interdisciplinary ways. So, I also I guess the whole another kind of part of my background, other than traditional, which I did, was when I was in med school, because I got paid for med school by going National Health Service Corps, which is a training program where they pay for your med school and you go back after med school and work in an underserved area, which is why I ended up in Jacksonville, Florida, because 25% of Jacksonville is underserved. But because of that, I had the opportunity to go to different places. Like in med school, I went to Alaska. I went to an Inuit village called Kotzebue, which is above the Arctic Circle. And again, almost like Appalachian Mountains, it's like I started to learn how to communicate with local nurses who understood traditions. And like, I didn't know anything about Inuit life, but I was able to learn that a little bit, for the 3 months that I was there. And, I think I began to learn the value of listening to people when they're not your culture, and try to understanding their culture, which is also something we don't learn very well in med school. So then in residency, I went to Australia, which is I did a 3-month rotation there in geriatrics, and I lived in Sydney. But the cool thing that I did there was I was able to work a little bit with the Flying Doctor Service, which is a program in New South Wales where they fly out to Outback. They have like a half morning clinic, like a derm clinic, a cardiology clinic, pulmonary clinic. And I would just go in these 4-seat planes to the Outback, do the clinic with the doctor as a resident, but the same thing. And so it's like, well, these people who are out in the Outback their culture. You have to understand their culture. And if they don't do treatments, a lot of times it's because of whatever cultural beliefs, and you have to go where they are. And so I think that those experiences all help me be interested in something I've been interested in my entire career, which is communication with different disciplines in the hospital, and trying to get where people are and patients are in their meet them where they are, so to speak. And that's kind of how I have done my whole career. After I was a resident, I did for traditional office practice for a bit, didn't like it very well, 15-minute slots. I had all these older people, took them 10 minutes to get up and off the exam table. I couldn't stand that. So when I had the chance to be a hospitalist, when it first started, I was real interested in that. And as a hospitalist, you can work with different disciplines. You can communicate with different specialists. You can try to change the culture. There's a lot of good things about being a hospitalist that I like.
James, it seems like you get a wide variety of experiences. I just wanted to hone in on the interdisciplinary dynamics between working in a hospital and working somewhere more rural, just like you said, in Appalachian Mountains. So how does interdisciplinary teamwork differ, and what are some takeaways that you learned from that experience?
Well, as opposed to what else? I mean, you always have to work with a team. So, I mean, in a traditional office practice, there's not a whole lot of interdisciplinary work, which is one of the things I didn't like. It's basically you, your nurse, your medical assistant, and the patient. That's it. And there isn't a lot of communication with other specialties, which I like. I mean, I think we all like to think that we're multidisciplinary, but we go back into our silos that happens all the time. As ICU nurses, you're in the ICU, the intensivist comes in, but the cardiologist comes in and he's back out doing whatever, or she, whatever they do. We know what they do, but you know what I mean? They go in and out of the ICU and you don't ever see them again. So it just, I don't know how to answer that exactly. Just trying to communicate the best you can with different disciplines, trying to give them the respect. And that's the other thing is I feel really, it's one of my pet peeves is when doctors don't respect other disciplines. You can see that they go in, like a speech therapist is doing their job. You go into and a doctor walks in and doesn't even acknowledge that they're there. That to me is just, that's got to stop from a medical standpoint, I think. And that interdisciplinary part of it starts with respecting that other disciplines can, that everybody plays a role in the hospital. And that's maybe what I learned. It's just like that it's every role is important, no matter what you're doing. I mean, environmental services, if you get these people with COVID, they had to clean the rooms and they were exposed just as much as everybody else was. And nobody gives them any credit for that. They had to clean the rooms. We depend on them to clean the rooms. Cafeteria workers, when I was at FMS, one of the things I did was go through every single department and interview each department and put, it was more of a promotional thing, but reviewed every single department in the hospital, what they did. And they're all trying hard. That's really important to understand as a doctor, and especially with nurses, that everybody has a role and they're all doing the best they can.
And James, just going back to you mentioning culture, because you've worked in a lot of places more than maybe some travel nurses, but going to Alaska and then going to Sydney, Australia, how was the culture different, or how did you adapt to the culture versus coming from Massachusetts and living in like the majority of where the states are? What did you have to change to maybe better suit the population in Alaska and in Sydney?
Well, I don't know if I can have more exposure than travel nurses. They're everywhere. But no, I think you just have to change. I think you have to change your attitude. You go, anybody who's done international travel knows that you go into a different culture and you can't be American. If you are, you're just going to be, you know what I mean? I mean, you can't just be, you can, but you're not going to learn anything, and people are not going to pay attention to you. So you have to be a little bit more humble and go and change your approach and listen to what they're saying and try to understand why they didn't do a certain treatment because they had this or that belief, and respect it. That's I think maybe what I would take away from that. And just be humble and listen. I mean, it's just like, not even if you're, just go, as I said, you go to international travel and you go somewhere, you try to learn their language a little bit. I mean, you should. If you don't, I don't think you're going to be as successful getting around in the country. You go to France, you try to, or Italy, you learn to say ciao or arrivederci. You have to learn how to say something in their language. And that's just one little thing.
Yeah, we have the same issue in Thailand, where if you don't open up to the culture and communicate, get to know them, learn their language, they look at you as you're not nobody in a sense. But yeah, just like you said, you have to adapt to the culture that you're in. You just can't be American per se.
So it's like a respect thing. Like, you're at least trying to like learn something. That's just, especially as a nurse, you're always telling people what to do. And it's like good to show that appreciation. Like, yeah, I'm telling you what to do, but also I'm also here like for you, and like you're trying to almost get involved in their way of life, not just tell them what to do.
Yeah.
And you could reverse it. So like, they come to the United States and they're in your hospital and they speak broken English. Well, you need a translator. I see a lot of doctors going in there and not just doctors, other healthcare workers going into people who barely speak English and try to communicate with English. We got to get a translator. Really, that's not fair to the person.
You make a very good point, James. Everybody in healthcare, and that's something we could talk about, is this time window. We're too busy crunching in the numbers into the insurance computer banked for Epic and these computer systems, and we're decreasing patient interaction time where we don't have time for a interpreter. And better yet, we just rather do an assessment. As long as you're good and you do a smile and a thumbs up, we could leave the room per se, but not understand what the patient is going through. And as you know, sometimes they're going through things more emotionally than physically of what's happening in the hospital, and that's where they need more communication, involvement.
Unfortunately, my hospital and probably other big hospitals. I mean, ours is a mid/big hospital, but we have Spanish translators live, and then we have the video translator. But maybe other smaller hospitals don't have that. That makes it hard. If you're a small hospital, you don't have any access to video translation. Although I don't know why they couldn't get that. That's just a matter of the hospital paying for it, isn't it? I don't know.
So when it comes to cultural things, it seems like communication is a barrier where we need to adapt to culture and open up and communicate. When you were working with the underserved, such as in Jacksonville, Florida, or in the Appalachian Mountains, there's something that you realize that is missing from the underserved there with healthcare? Is it the uninsured? Is it the lack of education? Is there themes that you notice that we need to better improve healthcare in those areas?
Oh boy, that's just such a huge topic. And it's hard to answer that. How to answer with low income, underserved areas. There's so many interventions that have to be done. It's almost impossible to try to put your finger on one or two things. So I think that's why it's so difficult for poor healthcare access areas to get better, is that it's so complicated. It's low income, it's food, it's not enough access to proper foods, it's transportation, all those kinds of things play into it. And you got to can you fix them all? No. Maybe you can. It's the community paying attention to that area, and they don't, because that's why they're underserved. The money doesn't go to them, because that's not where the people that have money are. It goes to the people that have money. So I don't know how to fix that.
Then Jim, like for example, the state of California, they have such high income tax, and there's so much money being dumped into healthcare, to the homeless, to the underserved populations. But yeah, this issue is like a revolving door. It's still the same issue no matter how much money we dump in it. So is the issue just access, and why are people not getting this access if there's so much millions and millions of dollars going into this? Because it seems like the budget always increases for the underserved, but yeah, it's still the same thing over and over again.
Yeah, as I said, it isn't just one. It isn't all money. I don't know the answer to that. That's why I do cartoons. I can make things funny and talk about various social things on my cartoons and doctor interactions, stuff like that, and laugh at it, because I don't have a solution. A lot of people don't, but you can point out you can point out in cartoons and comedy. You can point these things out, and maybe a little bit more focused way than just kind of talking about it with slides. So, I think there's a lot of great political cartoonists that make unbelievable points just with one cartoon. So, that's why I'm interested. I've been interested in entertainment forever. I just haven't figured out, exactly. I've been doing cartoons on Instagram, but I did spoof videos, and, I've been toying with whether to do videos on Instagram, and it just sort of it's continued evolution for me for how to use my interest in creation. I made the games that I made. I've done that. So there's those are all things that all circulating around medicine and really not solve anything. It's just entertaining. And that's another thing. So what is entertainment? Entertainment. Why do we deal with comedians? They don't really solve anything, right? But they make you laugh, and that's fun. And they do make you think sometimes.
That's true. It's like, because if you think about it, a comedian has like free reign. So it's like everything's for satire, for comedy, right? So they almost have like free reign to talk about whatever is kind of going on. So they could shed light on a topic in like a different way versus somebody that has maybe like an agenda, or maybe somebody that has like these different beliefs. For most part, comics are more open-minded, so I feel like they're able to joke around with a lot of stuff, and that joking around is able to open up a different thought process in people's minds, because they look at things a little bit different. Because especially when it comes to, for example, like religion, some people get really uptight when people make fun of religion, but some other people, it's funny, it's humor, it just sheds a different light, where it's like, well, we're all kind of the same if you think about it. It's just that opening something up to comedy just allows you to have like just a different viewpoint, a different idea about something. So for me, it's not just more like entertainment. It's just like, it gives you another way to think about something that you haven't thought about in that way. Because if you can make fun of it, it's almost like you know about it a little bit more, and you're not as judgmental or not as tunnel visioned about something, because you can make fun of it. You don't get uptight. So it's like you're more of an open person.
Yeah. You make a good point. It's like your perspective could open up without feeling the judgment, and also that your opinion is getting like kind of shut underneath the rug. Like it's still valid because it's produced by humor.
Right? Yeah, it allows you to rethink stuff, because somebody makes fun of you. You're like, okay, yeah, no, that kind of makes sense. That is kind of goofy. And if you could laugh at yourself and laugh at the things that you do, it just makes you a little bit better of a human, because then you're more understanding to why people do certain things as well. So then, Jim, how do you feel about the state of comedy now? There was that award show where that comedian Will Smith slapped that comedian on stage.
Oh yeah.
And then he came out with a special like talking smack about it. So what do you think about the state of comedy now? Have you ever been to Austin?
Yeah, I have. Yeah, I've been to Austin and Nashville, and certainly I've been to those places. But I mean, there's a lot of comedy. When I was trying to think about maybe being a comedian, there wasn't hardly anything going on. There was just you can go to a stand-up comedian club, and that was it. Pretty much. Or you go, and then you get noticed by Saturday Night Live, and that was pretty much the only way it could be that. I'm not a stand-up comedian, but I've done stuff on video in the past as a resident in med school that I think I could do. I just haven't done it yet. But now with social media, you can do a lot of stuff. You can be. I won in college. I won my college speech award, yearly speech award, by being 4 different characters talking about death. And I had different voices, and I can do that. I just haven't done it yet, and I've just been doing cartoons. So when I was talking about roles, I'm not the type, and maybe you guys aren't either. I don't know, but I'm not the type of person who's going to be able to come up with these great solutions to fix social ills. But I have a role, and so do you all, to you can point out things with whatever talent you have. And I would say that for anybody else who's listening. I mean, if you have a talent, you may not be the person who's going to create congressional laws or be a leader, but you can still play a role in pointing out certain things about your profession and whatever talent you have. Like you're a musician, you can, I don't know what musicians can do, but for that. But I just think that you pick your talent and you see what it is you can contribute.
Mm-hmm. You make a very good point, Jim, because everybody has a role. People call it passion, purpose, and no matter how small your role is, you're still making an incremental impact on the current state of what's happening of affairs to cultivate a new perspective, new change, or whatever it is. Just like in your case, you're practicing medicine, but also you're practicing everything else you're doing on the side with cartoons, and laughter is medicine. So if you're providing laughter to people, you're ultimately doing medicine in just your own way, and that's amazing. It's an art, right?
And I mean, all my multicultural experiences, I have all these views, and how to take care of patients and how to interact with patients, but to try to synthesize it together into a cogent plan in order to fix America's ills, I can't do that.
How has your perspective changed about medicine? For example, when you were very early on in residency, maybe you're super excited about healthcare.
Yeah, I've been in practice for almost over 30 years, really, if you count med school, and it's become much more corporate, much more metric based. When I was first, the physician patient relationship is kind of splintered. It was just when I first started, it was really just physician with patient alone, with with nurses around to help. But now there's like everybody's in the pie. I mean, the metrics are ridiculous. I know what they're trying to do. They're trying to make out, the payment has gone from just you pay your doctor cash or whatever. That's what it used to be. To all these third parties are involved. So that's made it much more complicated. And so people need to know, what are they getting when the patient goes to the doctor, what do you do during that visit? How do you measure that? How do I know how much that is? That's why this is a problem with, that's why specialists get paid so much more, is because it's easy to say, put a number on a procedure. But if you are a pediatrician and you convince somebody not to start smoking, you've saved that person's life maybe later on, whereas you don't get any credit for that or any payment. Whereas, you get a heart surgery, and that pays a lot of money for a procedure because of all the stuff that happened up to that point, which somebody could have stopped before. So I think, one of the things that has happened over the years is payment has gone from cash, that whatever doctor charges, to people trying to figure out, well, what happens in that room? How do you measure a person's interaction? Now we're thinking about outcome measurements. So like if you're in primary care, what percentage of your patients have a stable hemoglobin A1C? That's the kind of rudimentary thing they're looking at now. What percentage of patients have had a colonoscopy? And they pay you based on, your insurance company will pay you more if you have that higher percentage. That wasn't the case at all when I first started training. There wasn't any of that stuff. So it's, and I think the insurance companies and Medicare the relationship is sort of fractured, because patients go from one doctor, the insurance changes, they have to go to the doctor's no longer paid for, so they have to go to a different doctor, whereas you used to stay with your own doctor. So those are things that have changed over time. I think it's going to change in a good way, because I do think that the people that are getting trained now in medicine, the nurses, they see all these problems with our healthcare system. And I do think that there's hope for that generation of people to take these issues and try to change. I think they're changing already. There's way more women than there used to be. There's more, Blacks and other non-white people who are getting into medicine. And I think that's good for medicine. It's good for patients in the long run. So those are all things that are going in the right direction.
Yeah, it's almost like there's like hidden fees associated with like medical medical care? Because like you said, there's some sometimes it's more outcome driven where you get paid out based on your outcomes. But is that even fair to say? Because ultimately the person's going to do whatever they do. Only thing you could do is maybe educate and provide some prevention, maybe put them on some medications to make them a less risk for heart attack or stroke. But do you see that the way medicine is changing and the way it's getting charged and the whole cost associated with it, do you think it's changing in the right direction and in a fair way? Because it sounds good, like, hey, we should pay our physicians that to make it outcome based, but then like you realize that, hey, not everyone's gonna follow these protocols or these procedures or these things that you put them on, and it's almost like you're putting your income in someone else's decision, which isn't always fair. But then you have to also gauge the success of the physician in some manner, right? So do you think the way medicine and healthcare is moving, you think it's moving in the right direction, or is it just complicated and we gotta just move somewhere? So it's just like wherever we move, we just gotta move.
I think it's very early on with outcomes. I mean, right now it's not really great. I mean, that's not the colonoscopy percentage, and the hemoglobin A1C is dependent on the patient somewhat. It's dependent on, you know, their community supporting, whether, if you've got a bunch of people who are in lower income or underserved areas, that's not fair to you to say their hemoglobin A1C is at 13 when somebody who's got more advantages, their patients can maybe do more to keep their A1Cs down. But so I think it's just really early, and eventually I think it will change to be better. But right now I don't think it's better. People are struggling with how to measure the interactions. That people are offering payment for group therapy. Like if you got 20 diabetic patients, you can get paid instead of seeing it one-on-one, stuff like that. But we're still on the RVU system. You guys are aware of the RVU system, right? Right. That's how doctors get paid. It's called the relative value system, relative value unit system, where a national committee, has decided over the years. It's basically the Medicare Center for Medical Services, CMS is the name of it. They decide for every possible thing what the relative value unit of that is, which is hooked up to what you get reimbursed for. For example, like let's say a relative value unit for 10-minute visit is 1. I'm just making this up. So relative value unit for a surgical procedure might be 12. Okay, so that's hooked up to the money. So it's 12 times the amount in terms of what you get reimbursed or whatever. So, and if you look up that's why the coding of the ICD-10 codes, what doctors are supposed to put in the code, they hire coders that do this in the hospital to convert what doctors say in their notes to a code, and the code is hooked up to an RVU. So if a surgeon, let's say cardiovascular surgeon, will say he does this procedure, which is this code, he used this material and names all the materials, all the equipment, and may say that he worked with a surgical assistant. Everything has a code to it. All that is listed, like there may be 20 codes to the surgery. Those codes are then converted to RVU units, which are then converted to reimbursement. So the primary, procedures have lots and lots of RVU codes. Cognitive things have very few. So like you basically can do a limited, moderate, or an extensive visit. That's it. If you spend an hour and a half with a patient and convince them to go from, they're you work with their goals of care, and you convince them not to do invasive procedures in the ICU, for example. You do an hour and a half of that, and that's paid about the same as you spent 20 minutes, half an hour. So it doesn't matter how much time you spent. It doesn't matter how good you are at it. You can only do one certain code, and that's what you get reimbursed. So that's not real fair for cognitive services. But the problem is, how do you measure that? It's very difficult to measure how good you are when you're talking to somebody. It's easy to say, hey, I did this procedure, but what if there's a bad outcome? There's no measurement for that. They're doing readmissions. They're doing readmissions. I think that there are some outcome things like surgical site infections, which I'm sure you're aware of. Those are complications, but they're also very rudimentary, only a few. So there's still a lot to be, a lot to make it more equitable with between cognitive and special and procedural. I think that's what the public is saying.
Thank you for sharing that perspective. It sounds like there's a lot of incentives in healthcare. Maybe they're not the most beneficial for doctors or even patients, because if I have like a gallbladder issue, cholecystitis, the doctor could spend an hour and a half teaching about exercise, nutrition, and getting my stones decreased, reabsorbed so I could have a healthy life. But it seems like there's just a better incentive to getting my gallbladder removed. It's more beneficial for me because I don't have to go through all the diet and exercise. I'll just have removed and take a pill. And there's also incentive for the doctor just to remove the procedure because he's able to bill it, which more benefits the insurance companies, the hospital, and ultimately himself, right? So it seems like the incentives are not the most beneficial when it comes to both the doctor and the patient themselves. It just seems like the insurance companies are getting the most benefit from this, which is third party. And the whole thing is about patient care and patient safety and patient health and wellness, not the other way around.
I'm not sure gallbladder is the best example because, you have to take your gallbladder out if it's sick. But I get your point. I think you're right. As far as there's a lot of third-party interference and everything we've been talking about.
And then also I spoke to somebody when I was rolling in jiu-jitsu, and this doctor said that healthcare would be running a lot better if we created a single payment system or single payer code, or I'm not sure the lingo that he used. So if you're billing or coding a patient, are you coding or billing him multiple third parties or multiple codes? That's making it a lot harder for, he was an orthopedic surgeon or orthopedics, where he had to probably call multiple insurance companies to pay out or get a reimbursement for the patient versus using a single payment system. So can you tell me any information about that or what you think about that?
I don't think every doctor is in favor of a a single payer system. I am, but that doesn't mean, I can understand the issues people have with it, but I do think it would be a lot easier to have one system. I'm not married to it has to be government, but, some way of doing a single payer system, I think would be easier and a lot. There's some disadvantages too. Then you're stuck with one system. You talk, that I've read some stuff about the National Health Service in Britain, and that's not doing well either. That's a one, but there's other countries that are. I'm not sure. Right now, the system isn't great for the United States, and I'm not sure exactly where it's going to go, but everybody knows it has to change. I think a single payer system would work better, but there's downs to that too. So that's why I go back and do cartoons and do games, because it's a lot more fun.
And Jim, what does it mean when people say a single payer system? Does that mean like the governmental healthcare, or does that mean healthcare for all program? Is that what that is, or what do you mean by one payer
That
system?
means that if let's say Medicare is the typical example. if everybody had Medicare, Medicare would be your payment system.
Okay, so you want to have all the other insurance companies.
Yeah, all those insurance companies would go away, but it doesn't have to be Medicare. I mean, for example, it could be United Health Insurance. I'm just making up, and it could be a private thing. That's the only one. But you know, that's hard to do because how do you control the payment system? And you know, it's like, who controls this payment system? Is it the government? Is it a private corporation? How do you decide? How do you access the whatever it is, Medicare, to change things? You know, what if they do things that are completely off the wall? You don't have anywhere else to go to. So those are, you know, but if there's a system set up that there's a way you can access and change things, and they're good at reviewing what's gone wrong and how to make things better, then you know, one payer system would work. But yes, that's the typical example is Medicare.
Yeah, because like on paper, it's a good idea, but a lot of my family is in Poland, and their main issue, they are a one payer system, and the thing is that then everyone has access to healthcare, which is a good thing, but then the time to get actually treated takes a really long time. Like my grandpa needed a surgery.
That's the argument against that, but that doesn't mean that it has to be that way.
Right. Yeah. It's just basically if you can make it efficient and if you have enough physicians and clinics around to treat like a giant population, you know, then it works. Because like for example, my grandpa needed a surgery and the surgery wait time was, I think I told him 2 months. So we literally had to pay cash to move up on that board. Where then it's like if you have a system that's flawed to that extent, then you're kind of almost, the idea of healthcare for all is almost going to waste, because then you're guareeing healthcare to people that have money, which is kind of like the same thing that it is now. If you have more money, you have more access.
That's the way it is here.
Yeah.
We have a 2-tiered system right now.
Right. Yeah. So it's like the thing is like, would that change anything?
You have a lot of in Florida. We have a ton of uninsured patients because they decided not to take Medicaid. You have Medicaid, and they can't find they can't find the doctor they want. They can't get the healthcare they want necessarily. I mean, you've all done that. You know, any nurse in the hospital knows if you have an uninsured patient, you can do whatever you want in the hospital. But as soon as they leave the hospital, who knows? You know, they can't get the doctor, they can't get their tests. It's a complete mess. So you gotta have. I do think everybody has to be covered. That's to me is like a no-brainer and an absolute must. You have to get covered somehow so you can get some health care.
Right. And that feeds into the whole preventative thing. We don't have a lot of preventative medicine here in the US, but if you gave healthcare to all, maybe there will be like a greater push for prevention, because if you can prevent something, then you don't have the burden of getting stuck with that cost when this issue actually develops or actually starts. So in like the long run, it's a really good thing, because then maybe instead of people getting focused on how am I going to pay for this visit, how am I going to be able to afford this treatment, this medication, people might be more prone to just going to the doctor and just getting preventative stuff. And then if you have more people that are more involved in prevention, then there's a greater market for prevention, and maybe the government could step in and then make it more of a viable thing. Because like I said, there's no prevention that you see. You go to your doctor, and instead of getting told, hey, change your diet, change your lifestyle because you're hypertensive, they get put on a statin or they put on antihypertensive medication. They don't even get a chance to do it because physicians know that, hey, the likelihood of this person actually taking the steps to change their lives, to change lifestyles is super low. So let's just like maybe not focus on that and just focus on the future of just putting them on this medication, because at least they're going to take it, because you're kind of scaring them in a sense.
Yeah, I mean, I don't think there's any perfect health system. I mean, you know, go all over the world and look at different health systems. You still have people that don't follow directions, you know, so you're going to always run into obstacles no matter what system you have. It's just a question of, you know, I think access is number one. And then beyond that, it's like, well, how do you make it as equitable as possible to everybody? Hard to do.
Yeah,
I don't think any country's done it perfectly. And I'm not an expert in international, although I have been in different spots, but I don't think any place is perfect. I think the U.S. has gone downhill. Certainly, our mortality statistics have gone downhill. So we got a lot of work to do in this country.
Yeah, and then piggybacking off what Matt said, because you mentioned like bias and maybe physicians just choosing the procedure or the option that almost makes them more money. Have you seen that ever going on? Because if for example, if there's like a higher bill rate for taking off that testicle or taking out that kidney versus doing some other treatment because you can make more money off it, does personal bias and does financial bias play like a role into maybe decision making where physicians are surgeons are maybe more prone to take this step because they're guaranteed more money? Anything like that? Have you seen, not you
I don't.
personally, but in general?
I mean, I'm sure it exists to some degree, but I'm not sure it's as prevalent as the public thinks. I think for the most part, most doctors, surgeons, proceduralists just do what's medically indicated. And I think people think a lot more that doctors do everything for money, and I just don't think that that's true. I don't do it that way. I mean, if I do something that is justifying a certain, reimbursement, then I should put that reimbursement down. There may be ways you can fiddle with your RVUs or to make more, but it's, is it, I think might be, it's justified. If you do the work, you should get paid for it. But I don't think in general that doctors and proceduralist surgeons, etc., I don't think that they're upbilling on a massive scale. Maybe a few bad apples are, but I think most people try to go into medicine, do the right thing, charge what should be charged. But I can't say that. I'm sure there's people that upcharge, just like that's like in any. It's not just medicine. Any discipline could do that.
Yeah.
And you ask a good question, but it's hard to answer because there's a lot of unconscious bias, right? Just like we did a podcast episode. There's studies that show the unconscious bias in healthcare providers with that the minorities get less effective technically healthcare. It's like asking a nurse, are you giving that sleeping pill at night so the patient could fall asleep so they don't bother you, or are you taking them for their best interest so they could sleep and recover so tomorrow they could recover and leave the hospital and decrease admission, right? Or decrease the hospital stay. So it's hard to tell which one you're doing. Maybe there's incentives in both a little bit for that nurse. But if you
that's totally true. I mean, a good example, and I did a couple cartoons about this, is sickle cell disease. I think there's a huge amount of pain bias, minority bias. We can't tell, it's all not objective how much pain they're in, and they get completely undertreated so many times. And just really, that's one of the biggest disease categories where I think bias comes in and does harm to patients. It's tough though. I mean, because there are a few patients that are pain seeking, drug seeking. They are, but I think they're few. They're in the minority. Just an example. And I try to, on my cartoons, I try to, anytime this kind of stuff comes up, I will typically try to make a cartoon that talks about that. So it's, and the nice thing about Instagram, and I guess we're switching over to social media right now, but the nice thing about it is all the comments, the interactions you can have in direct messages, the stories, that go away in 24 hours. There's a lot of really interesting interactions you can have on social media just from putting up a cartoon of something. I've been really pleased with just kind of the communication and people I've met on social media. It's been fun.
Mm-hmm. Yeah, it's the beauty of it. It's just like you spark ideas, you spark thoughts, and you spark communication. And then once you get people communicating, they're able to talk about different topics. Maybe they could have an idea of how to, change certain things. It's like it's the beauty of just like social media and just off entertainment and off humor. It's like it puts you in a state where you don't feel attacked usually, unless you're being offended by the joke, of course. But lets you lower your guards, because when you're able to laugh and make fun of stuff and you're okay with that, like you're not as in like a heightened space where you're like in fear of being judged or in fear of something. It makes things a little bit more easy to talk about, more relaxed, and then you could genuinely share ideas, topics, share things about yourself, and honestly communicate without feeling threatened or feeling like someone's going to judge you off the way you think about something or off the way
Well,
off you
yeah,
speak or
so
things like that.
there's a lot of people that take offense on social media, and you know that. I mean, if you're, anybody on social media knows there's all kinds of offensive, people taking offense and people saying things that are offensive. I mean, I wish that wasn't so. I mean, I wish it could be more, intellectual and collegial than it is sometimes. But that's I can't. Not sure that's going to change anytime soon.
Oh, it's for sure not. It's for sure not. Like if I was a little kid and I had access to Twitter or whatever like that, and I could just talk a bunch of shit and without any
Yeah.
kind of any kind of consequences, I'll be all over that for sure. Like why not? Being a little kid and be able to say whatever you want or things like that. But that's like that. It's like your responsibility. If you don't feed into it, it's almost like not going to exist for you. If you don't like that comment or if you don't respond to it, it'll fade away just
Yeah,
as easy as it came in.
That
You know?
people really should do is if they're offended by something, just don't put anything in, and just go
Kill
away
them
and do
with-
something
kill them
else.
with kindness.
Yeah, why are you
There's
feeding
so
to
many
it? Don't feed into it.
There's so many things in general that you can get offended by. Unless it's really going to hurt you badly, just sort of walk away.
Yeah. Because only people that are gonna talk negatively about you are either in their mom's basement, miserable about their life, or they're not even worth the time to pay attention to. Because out of all things that somebody could do with their time and in their life, they're taking the time and effort to talk down upon you or talk shit about you or say something negative. It's just like just shows what kind of person they are. Like out of all the things they could have said, they decide to type that sentence, and they probably thought about it for hours. Like, oh, I'm gonna get them. And if you don't feed into that and you don't acknowledge that, then that goes nowhere, dissipates to nothing.
Yeah, absolutely. Look at this. This is a card. I don't know if this is backwards. This is one of my cards in my card game. Can you see that?
Okay, yeah, doctor.
Dr. Blowfart. Is it backwards?
No,
I mean-
it's right way.
Okay, so Dr. Blowfart is the GI doctor, and would a GI doctor get offended by I gave the name Blowfart to him? I also I got Dr. Know-It-All, who's the internal medicine. That's my specialty. So it's like those are, I'm making fun of. I'm making names that people could get offended by. Hopefully not, because it's just for fun.
But it's healthcare, it's healthcare. Like we work in with people that are probably in like the worst parts of their lives and the toughest times of their lives, where you can't just be serious all the time because that's gonna eat you out on the inside and you're gonna go crazy. Like you're literally there's like working in the CVICU and ICU in general. Majority of our patients die. Majority of them die, and it's like how can you people like wonder how can you be happy in a time like that? Well, it's like you're not happy, but you gotta be able to have some kind of humor and have to be able to decrease the emotions of a situation. And the only way to really do that is just to joke around, mess around. We don't try to offend anybody or offend our coworkers or offend our patients, but sometimes you just gotta talk a little. Sometimes you gotta talk a little shit to de-escalate the situation and realize that hey, the reality that we live in isn't just death all the time. It's not always suffering. It's not always people crying. It's not always sadness. Like there is some kind of enjoyment and relaxation that you could get out of work in this kind of a field.
Absolutely. Yeah. I mean, the ICU is a great example where you just figure you can't use humor, but you can. You have to.
Well, Jim, how did you get involved with comedy, making cartoons to developing the war game, the Doctor War game?
Oh yeah, it's called Doctor Wars. And this was really interesting. And I don't know if anybody who's listening has any interest in making games, but I learned how to do it from scratch, and it was really interesting because I became a hospitalist, and within a few months, I just kind of was seeing how moving patients around was like a chess, a little bit like chess. Like patients move from one place to the next. There's always somebody trying to move them a different place, and I thought, hey, this is kind of like chess. So one morning I woke up and I had a complete game in my head, which is unbelievable. I don't know where that came from. I had a complete game in my head, and I said, wow, this is weird. This is I wasn't thinking about a game. It just woke up like that. So I said I should maybe do something about this. So I put it down on a piece of paper, fiddle with it a little bit. I put it on a poster, played with my family, and kind of, I was working full time as a hospitalist, working Monday through Friday and every third weekend. I didn't have a whole lot of time. So this took years and years of just free time that I had periodically. And, I tested over a bunch of people. I ended up, having a board game where you would get points for discharging people out of the hospital. And in order to discharge somebody out of the hospital, you had to match your cure to the problem. So they have patients in the hospital, they would have problems. It's a card, they'd have a problem card on top of it, and they'd have points associated with it. So, and then you have 4 different pieces. You had a nurse piece, a resident, an intern, and an attending, and they each move differently, like chess. And you have to move your pieces around to, and there's ranks. So like if the attending moves into a room and you just have your intern, the attending is going to outrank you and be able to do more to get rid of that patient. And then you have the nurse. The nurse is nurse is kind of fun because this is the board game, where the nurse moves can block you from going into the room. So like an intern wants to go in, but it can't block an attending. So like the nurse is sitting outside the room, the intern can't go in there. The intern and the resident can't go in there because the nurse is blocking the room, which I thought was real fun. Anyway, and then I got the pieces from England. I got the box from Atlanta. My wife works in the art museum, or worked in the art museum, and she knew people that could make the board. So over many years, I developed it, put it on Amazon, and I sold a lot of games, but I sold out, and I wanted to do something that game was sort of complicated. It took a while to learn it. I really loved it, but it took at least the whole game to learn that, oh yeah, I kind of get this. So I wanted something a little simpler for the second generation. So I made up the card game, which you can learn in 5 to 10 minutes, and it plays, you can play it for 40 minutes to an hour and you're done. It's kind of the same principle. You have patients, 5 patients on the board. Each patient has problems. They have points. Like you have a seizure, you have lung clot. They have different specialties, and then you have cure cards in your hand. So like and you don't have to know anything. It just, like, if you have a diarrhea card here, then you have to have a 10-point cure card in that specialty to cure the person. So it's basically matching it, and you also have to have the right doctor. So you trade doctors if you don't have the right doctor. Like, you can't cure diarrhea if you have an internal medicine doctor. You have to have the GI doctor. And so each person gets a doctor in the beginning of the game. And if you don't have, like, I may have Dr. Know-It-All, the medicine doctor, but I can't cure a seizure, even though that's not necessarily true, but that's how the game works, and so you trade. And then I have a super nurse card, which allows you to do things that you weren't able to do without that card. I have a Grim Reaper card, which you basically kills the patient off. So there's
get that power to a nurse, huh?
It's a kind of a fun. It's not that hard to play. It's fun. I played a lot before I kind of decided on the strategy. And so that's the one that's on sale for Amazon. The board game's out of print, unfortunately. I have to figure out how I'm gonna do that again and make it a little bit better. But I spend a lot of time fiddling with that kind of stuff when I'm not working in the cartoons. So, it's how I entertain myself.
You never know. It might be a fun game for night shift nurses to just, solve things like diarrhea, seizures, blood clots, and forgot the strategy. It's like Risk,
It's like it's good for new grads, so I know what specialty to call for what issue.
Yeah.
Right. Yeah. Well,
Watch out for Dr. Bluefart, man.
it's a lot of it's fun. It's a fun little game. It's not anything, earth shattering, but it's just like, if you played Uno or something, it's a little bit more complicated than Uno, but not too much.
Jim, where can people find you on socials or website or Amazon?
My on Instagram, I'm Dr. Ward's Game because of Dr. Ward, Dr. DOCTORS, or Dr. Wars DOCTORWARS Game, and same. It's Dr. Wars on Facebook. I don't even really do the Facebook. It's pretty much Instagram, I would say. I do it. I put the automatically up on Facebook, but I don't even. I need to do a better job of looking at my Facebook stuff. I just don't. I don't even know how to use Facebook.
And then, Jim, one last question we ask all of our guests: if you could have one cup of coffee with anybody, dead or alive, who would it be and why?
I had a lot of trouble with this question. I mean, my first thought right away was Jesus. You know, that would be a pretty amazing coffee. I think, unless I didn't know that he was Jesus. But I don't know. That's my answer, I guess.
Okay.
What would you ask him?
Yeah.
Other than if heaven is real.
Or if you lived.
I'd probably use him as my psychiatrist.
That's so funny.
Yeah, I mean, yeah, that's a very good point because I think
Really,
my grandma says.
I didn't that question's always hard to answer. It's like, well, who knows? We talked about a lot on this show, so who knows? I would ask him. I don't know. I'd ask him how should I change my life? I think I'd ask him that.
What do you feel you're missing, or do you feel like you're missing anything?
Uh, well, that's a good question. Now you're getting to be a psychiatrist. I'm not sure that's what I signed up
And
for.
maybe we're your Jesus. You never know.
It came in Peter form.
We'll let Jesus answer that question.
Sure.
Take the wheel. Yeah, I mean, my grandma always says that God doesn't punish you; our own thoughts punish ourselves. So usually, our own suffering comes from our own mind and everything else that comes.
That's so true. Yeah, I mean, I'm a perfectionist, so that's probably my biggest fault. It's like I don't think anything is good enough. That comes from being the oldest child, maybe. What do you guys? What about you? How would you answer that question?
I don't know.
Turn it around on the host, right?
I don't. It depends where I kind of am in my life. Like because we had a guest ask us the same question before, and one of my answers was Jordan Peterson. But that was I want to say like last year. Right now, who would I want to have a cup of coffee with? I don't know. It's a good question.
I'm asking you what you changed in your life. That's a hard.
Oh, what would I change in my life? Honestly, right now, I don't want to sound like egotistic or anything. I really wouldn't want to change anything. I don't really wish for changes. I just take things as they come.
Mm-hmm.
Whatever comes, I deal with it. I like problem solving, so that's probably one of the reasons why I wouldn't really change anything. Just because if there's a problem to solve, makes me kind of feel good because it means I'm doing something different. It means I'm changing things up. So I wouldn't really change anything. To be honest, not that my life is perfect and so great. It's just the fact that I like challenges, and if you take challenges away from my life, I feel like I lose meaning. So anything more problems.
How about you?
Jim, for me, it would be probably self-love, just learning not to be so overly critical, taking time, being kind, being gentle. And that's just not outwardly, that's inwardly just to myself. So I am my own worst critic. Just like you said, there's perfectionism in your life. For me, it's just my work ethic and just being too critical. Just knowing to slow down and say, hey, you did a good job today.
Yeah, that's tough. I think a lot of people struggle with telling themselves that they're doing a good job. It's really, really hard. I think it's, that's certainly something, maybe to answer your question, I could do better at. It's just giving myself credit for doing something. We could all, I don't want to say we could all, because some people give themselves too much credit, but most people, I think, are could do better in that particular area.
And And back to your piggy point of what you would ask Jesus, you said perfectionism, right? You said it's something that you're
And I don't
working
want to
on.
sound like this isn't a Christian thing. And it could be anything else. I mean, it could be any other avatar, so to speak, or
Yeah.
I'd be probably just as happy as sitting down with, somebody of the other religions. I mean, it's just
Like
somebody
Muhammad
who's
or anybody.
extremely godlike and knowledgeable is really what I think I would, Jesus, it just happens to be my background, but could be any of the others.
Yeah.
Yeah, I mean, no need to explain yourself. That was the perfect answer, right? Again, it's like, do you see how the perfectionism came out even in this question right now, where you're like trying to figure out if that was the best person you could pick,
Yeah.
right? So it's just funny how the belief of perfectionism gets poured into different aspects of our reality and experience. And, in this case, that was a good answer because that was the answer that Jim chose. So you have to give yourself that self-worth that, hey, that was the answer that I chose, and I
Yeah.
love that that was my pick.
That's pretty interesting. Yeah. Well, it's an interesting question. It tells you a lot about the person, who you pick. Maybe I wonder if you're going to interview somebody that says the devil.
Hey, I mean, that wouldn't be a bad person to speak to as well. Like, like why does that exist? A lot of
Or
questions
you
for
can
that guy
say,
too.
hey, I want to find out, why do you do all these things that make the earth bad? What's with you?
Jim, we just wanted to thank you for your time and acknowledge you for the knowledge that you brought, all your experience in healthcare. Thank you for bringing humor into healthcare and creating your own way of, laughing about the situation, the current affair of healthcare. So thank you for being on, and hopefully anybody that's listening is interested about the game. They could find it on the links in the show notes, so we'll add the description, and maybe see you on the next episode.
Sounds great. I really appreciate you guys having me on. Thanks so much.